What I'm going to share with you today is an innovation project that we undertook that sought to increase the number of patients we safely discharged from our A&E department, and if not the A&E department, then the next step on their journey, which would be our emergency admissions unit. Like all health organisations, whether commissioning or providing, there are competing priorities, and unfortunately at the end of our pilot project, when we were just getting a feel for what we might have to do to improve and what we were just starting to learn, it wasn't substantiated. So we thought, well, we'll have to look at our existing resources and see what we can do a little bit differently and reorganise ourselves, because we really felt that it was something worth doing. So the journey that I'm going to share with you is where we went in order to provide that substantive service from our existing resources. And obviously I'm going to do that through our patients, thinking about our patients being at the centre and their families, and tell you a little bit about what we were thinking about when we did what we did from that perspective. So in the very beginning, like I say, we wanted to sustain the service and increase the number of patients we safely discharged from A&E. We did have a very comprehensive intermediate care team, which was multidisciplinary and interagency in its nature: physios, OTs, nurses, even a couple of nurse specialists for older people, and we worked very collaboratively with our GP community. And although we didn't have a community geriatrician, we did have access to rapid access appointments in geriatrician clinics. So we had something really good that we knew wasn't being used very well. We also had a very comprehensive hospital discharge nursing team. So we wanted to improve the increase by 5% annually. Now I have to say we haven't been able to measure that because we're not at the end of our first year yet, but we have learned a lot of other things along the way. We didn't have any criteria for discharging our patients from A&E, and obviously that would be some of the reason why we didn't do it. And we also didn't really understand the type of patients that would be able to be discharged safely from there. So we thought that just at the end of our pilot we were beginning to learn what type of patients they were. And as we all know, the over 65s are the biggest consumers of health and social care. And really, if you take out children's services, maternity services, specific young people's services, then all of the rest of us, regardless of our specialty, will work with older people. So that started to make us think about older people's needs. And in the pilot project, we learned that our average age was 74. And I think there's something about that as well, because that taught us that we weren't particularly working with the very frailest of our society, and they were probably the people you couldn't safely discharge anyway, those frail ones, but we were working with what we've come to call the pre-frail. So there were people who were having falls, and it might have been a straightforward reason for that, or there might not have been, or people who were having big responses to simple illnesses such as infections. So using that information, we knew that to fulfil our objective, one of our aims would have to be to develop a framework around that. And we also guessed that there was lots of people involved, and because these were the people who were getting better quickly and weren't falling into a particular specialty, and sometimes were having several moves in the hospital, so there was lots of handoffs and referrals, and we know that there's always a risk with transfer of care. So we thought, well, we'll look at our existing resources, as I've said, and we've got this multidisciplinary team in the community, but let's try and get that in the front of the hospital as well, something that can mirror it and have the same ethos, the same culture, and therefore have a safer transfer of care. In our intermediate care team and in our intermediate care stream, because we have a whole ream of services, our mission statement is to maximise independence through improving health and well-being. And the reason for that is it's very, very easy to provide aids like walking sticks or Zimmer frames or anything else. I guess that it might be easy in the fracture clinic for them to pop on a plaster and send people home because they've got the carers to help them and so on. But it's about getting underneath that. What was the cause of the fall? What's the bone health linked with this fracture? What can we do now that might prevent that huge fractured neck of femur in the future? So that's the reason that we have that as our mission statement, and we're trying to get that culture into the front of house team as well. I've said that it was about discharging people safely from A&E, and by now, when we know that we're working with the over 70s predominantly, we know that older people, hospital isn't the best place for them to be sometimes. sometimes it's the only place to be, but it's not always the best place to be. And we reckon that if we thought about safety, quality and experience for our patients, safety in terms of clinical evidence and all the quality outcomes as well, then we wouldn't go wrong. But there's another bit about safety, quality and experience, because we were seeking to do something new with our existing resources, so that was a lot of change for our staff. So we had to think about safety, quality and experience for our workforce as well. And you'll know that I would move on to talk about change, thinking about those things. We had to get our staff to come with us, to change the culture for some of them, to work differently. We even had, in one of our staff questionnaires that we did, somebody commenting that I don't want to work in this team because I don't want to work with older people. And like I said before, we all do, unless you're in any of those other specific services, because statistically the over 65s, as I say, are the biggest consumers. We had to get the community team and the acute care team to work very closely together and to develop a common ethos and a common culture. We knew that we had to find some efficiencies in our existing resources so that we could have this new front of house team. And we knew that we had to have a common way of working so that everybody understood the language that people were using and also the documentation that was being used. Not least because we didn't want our patients and their families to be repeatedly asked the same questions over and over again. And we know that that's a huge challenge. It is a really huge challenge. And lots of the clinicians that we spoke to would say, oh, the trouble is there isn't anything as good as my own assessment. And we know that. And some of us will sign up to that in this room today. And probably I might be a bit guilty of that myself. So a little bit like our first speaker, I've got the gist, but struggle to talk through all the tools and techniques that we did do. But keeping the patient in the centre, but knowing that we had to change our workforce around that, we undertook some process mapping for both of them actually. What happened to our patients if they didn't get out with us, seeking to understand that in terms of the clinical evidence. And because we're working with older people, there's some good social studies as well that tell us the impact on families. And actually it's much more difficult. In some cases, we learned through our patient and family stories, we learned it's actually more difficult for informal carers to be a visitor than it is to be a carer in the community, caring for their own family members. We wanted to have a culture of standard work, but we had to understand what everybody was doing first, so we had to undertake an activity analysis, and we did do that. And then to get that sign-up, to get everybody thinking in the same way, and we're not at the end, but we've started the journey because we know that that's the best thing for us to do. We gave them some protected time and undertook a couple of day Kaizen event. So looking at the staff and if you think about the patient, these are all of the people that were involved trying to discharge, working with patients in a discharge way, but yet not discharging them very early in the pathway until we undertook our pilot study. So we've got fragmented, even the discharge nurses are separate. So we've got 2 that work with the complex discharges, 2 that do rapid response discharges, but from the rest of the hospital, not the front, not A&E. And then we've got all of the hospital MDT, and then we've got the physios, OTs, and the medical staff, and so on. But then we've got all of them in the community as well. So there was a lot of handoffs and a lot of transfers of care. After that, we knocked out. We brought all the discharge nurses to be a single team, and that's a challenge that's we've succeeded with. I would say that's very, very successful and quite a harmonious little gang now. And we built the intermediate care team, so the therapists in reach now, rather than them handing off. The therapists in reach pick the patients up on a 7-day rota. That was another new thing. We had to introduce weekend working, and so that the patient can have the same team, and so we started to reduce the handoffs, which was one of the things that we wanted to do in the very beginning. So, in A&E previously, we didn't have anybody thinking about, oh, is it possible that this patient could be discharged from A&E or from AAU? So we thought, well, let's keep it simple, because we don't all understand that. We all understand our own specialties in the best way, and we we don't understand, sometimes we speak like specialists. So when we go in, when we were in A&E, who work in a very different emergency care way to the intermediate care team, they didn't think like we did, and so we had to have something simple, and we thought, well, all we want you to do at triage, think, can this patient be discharged? And we provided that very simple flyer. We also had to have a very straightforward pathway. So knock out all of those people that I showed you before, and what would that mean for the patient, and when would they go? And if you think, oh, do you know something, I think this person could be discharged, what would be the pathway? What would be the steps? Who do you ring? And we made it very simple that we have a 24/7 into the intermediate care team. We have a 24/7 mobile phone, which is answered by the senior nurse or senior therapist on duty at any one time, who uses straightforward, standardised triage tool, which we didn't have before, and we've got this very straightforward pathway. We did follow that up with a little observational audit to see if it was used in the standard way, and we found that it was. Now, like some of the other speakers today, given the headlines about targets and money yesterday, I was a little bit hesitant about having my pound signs in and my pound notes or my tenors or whatever I've got there. I think that it is very relevant because, remember, we were funded for a pilot project. We believed that it was successful. Competing priorities for our commissioners meant that it didn't become substantive, so we had to do it from existing resources, and we had to demonstrate, well, how could we safely pull out of other things and put the investment somewhere else. And that we just looked at based on 2 patients a week with all of those staff, all those figures that I showed you, then we could save that little bit of amount of money there. In terms of having clinically effective and safe care, then we didn't have a standard referral system, but neither did we have a standard assessment documentation, so that actually now in A&E, in triage, the nurses are kicking it off, and the medical team as well, and we use this in the intermediate care team. And sometimes patients are coming out very quickly, and we've only got enough information here so that we feel confident we're having a safe discharge, but we'll continue to get that information. It's a very comprehensive assessment tool, and it's based on the principles of the CGA, Comprehensive Geriatric Assessment, and there's lots of clinical evidence around what you would need to have such a safe tool, and that's what we have developed there to support our rapid discharge pathway. We didn't have clear roles and responsibilities because we were bringing lots of people from different teams all together, so we had to really think about our workforce development and what that would mean in service redesign. And there's something very simple as well about actually people want to work where they want to work, but when our patients and their families are coming in, they have their expectations about receiving what they want to receive. And if you want to deliver the best services, you need the best staff sometimes, so we did have to invest some time with the staff to make sure that we did have the best workforce and a committed one. So there was something around practice development and sharing knowledge and skills, and not about every single person in the team having all the knowledge and skills, but just how we know interprofessional work and works in a multidisciplinary team, and you informally share your knowledge and skills, and so we did amongst all of the people that were involved here. And I've already described to you that we did develop a single point of contact in our intermediate care team 24/7 with the senior nurse or therapist. We're very clear that it needs to be the senior nurse or therapist so that we'll have consistency of decision making. But I think an example that it's not always the nurses, it's the therapists as well that share that. And we tried to keep it simple really, just so that we could share our new service much more widely. I think we were very fortunate in South Tyneside because the community health services were part of the Foundation Trust, and working as I do in Gateshead and Sunderland, it takes you longer to do such things when you're working with your other organisations, but that's just the nature of intermediate care, and absolutely fine that we have to do that. I think the other thing that we did was try to make all of these forms available electronically, because there was lots of bits of paper flying around and different notes. We developed one community record so that whether you had community matron, district nurse, acute care team or an intermediate care team or whoever else in the community, whoever came to visit you previously, the patients and their families had 4 sets of notes, whereas now they have only one that everybody uses. And we've had some very positive feedback about that, particularly from the informal carers who sometimes use it to communicate between the visiting disciplines there. And for submission of some of those forms, we've developed a central email address for sharing other bits of information. I think we have, in terms of sustaining our changes, well, we're not at the end of our first year yet, but we have undertaken some things that's given us some confidence, but we fully understand that we are working in a cycle of continuous improvement really, and what we're doing this week might not be what we're doing in another month. We've done some observational audits, as I described earlier, just to check whether we were working in a standard way and using the assessment tools in the way that we intended them to be. We've undertook activity analysis pre and post, and have found that we've made a difference. And we haven't had any of our patients, like most acute trusts, we look at our readmission rates on a monthly basis, and none of the patients that we have discharged up until now have been readmitted either from A&E or from our emergency assessment unit. So I think there's something around this criteria that we've developed. It is safe and we are making safe decisions around that. We've obviously got some good relationships that didn't exist before, but I do know, because community services are housed with that acute trust now, that will also have made a difference. But what we're starting to do now is develop some relationships, some much stronger relationships with our colleagues in the local authority, in community services, social services. And I think that because we're taking patients out and we're working to deal with today's crisis, but also with an eye to providing the crisis of the future. And I gave you the example of the falls, where we might think about referral onto the falls team, making sure they have a bone health assessment, perhaps preventing that fractured neck or femur in the future. Then we're also seeing it because we're working with our patients longer. So we're doing some mental health assessments, so working with the dementia strategy to try and have earlier diagnosis. And that's what I said at the very beginning, our mission statement is to promote independence, but through the promotion of health and well-being. It's about getting those things together. So I do think that we're making a difference in discharge. Now, the intermediate care team has always had referrals from the hospital, but they've really grown. And pre this piece of work, of the referrals to the team from hospital, only 80% of them came from A&E, and now 70% of all referrals to that team are from the accident and emergency department. So I think that we're starting to see the fruition really of our work. We've tried to share it in places like this, but share it right throughout the hospital as well, particularly as I've mentioned falls, I've mentioned dementia, so the sort of things that we're seeing, working very closely with our day hospital and the rapid access clinics, with our elderly care physicians there. And in summary, I was privileged, I think, really. We work very closely with our patient and carer involvement team, and they have a very structured programme, and everybody gets their turn to have their patients' stories collected, and they've just started to collect ours in relation to this pilot now. And I think I do think it was a privilege to hear what this daughter said about the care that her mother had received, which I'll just scribble down yesterday. I only heard it yesterday. The doctor that she's referring to is the GP. So this is in quotation marks. With Dr. So-and-so saying to me, Mary, we're looking after your mum together. And we're doing such a good job, We're doing such a good job. Really, I have to say, it meant the world getting her out early, when we did, from the accident department. And I think that sums up that our patients are having better experiences than what they had previously.
Questions? From your perspective, what was the hardest thing to do or to change?
Well, I'm a nurse, and it was the discharge nurses. Yeah, it was the discharge nurses. Because, and to be fair to them, if you read the Department of Health direction for discharge planning nurses, it says that they should concentrate on the 20% which are complex.
Yeah.
So these aren't particularly complex. And I've said that, you know, we now talk of them as probably the pre-frail rather than the frail. So it was getting them to think in a different way and about working with a different group of people, a different group of patients with different types of needs. So I think that was.
So if they're freeing up time with the less
yes.
complex ones, enable them to spend more time with them.
And we had 2 separate teams bringing them together. That was really hard because they felt they did this type of work and we only do the complex and you just help the ward staff and actually their ward nurses should be doing what you're doing anyway, and so it went on. So that was challenging. But they're in one of the better places now out of everybody that's involved.
With the effort.
Yeah, absolutely.
Any more points, comments, questions? No, thank you very much, Emma. I think that's brilliant. That's very much.